Now, another technique for delivering smallpox vaccination was invented in the 1950s. It is these multi-use nozzle jet injectors, which I abbreviate MUNGs, invented by the military for high-speed vaccination of recruits. They are capable of 600 to 1,000 doses per hour, and they were been used in mass campaigns from the 1950s through the 1990s for a variety of vaccines, including polio, meningitis, yellow fever, measles, and influenza, in addition to smallpox. And they were used in the first half of the smallpox campaign with special intradermal nozzles I'll show you shortly, from the mid-60s to the early 70s, mostly in Latin America and West Africa, and literally tens of millions of doses of smallpox vaccine alone were delivered by them. And overall, for all the vaccines, I would estimate billions of doses have been administered by these devices, but they were withdrawn for safety reasons in that they were probably transmitting blood and hepatitis B from one patient to the next. And they have been replaced now by disposable syringe or disposable cartridge devices, DISGs or JICGs, that avoid that problem. The bifurcated needle was invented in 1967 by Benjamin Rubin of Wyeth, and the royalties were waived for WHO's use in the smallpox program. And basically, they pretty much replaced these complicated, expensive, difficult-to-maintain devices with this quite simple one. They required a change in formulation because the tines between them only hold 0.00025 of a millimeter, and most of that doesn't get into the patient anyway. That most of that sits on the skin. Here's a close-up of the business end of the intradermal nozzle on the Pedijet Mungi. Basically, the squirt comes out through this tiny orifice here at a 45-degree angle, and it's recessed in this area so that it's not actually touching the skin, and that air gap weakens the stream enough to leave the dose in the skin. As I mentioned, hundreds of millions of doses have been given for smallpox. The French neurotropic virus vaccine strain of yellow fever in West Africa was delivered by this technique, and some BCG, but it's not recommended anymore. And you can get the same effect with a traditional ion nozzle shown here if you simply take a short piece of tubing or a garden hose and cut it off so you create a several millimeter gap between the skin and the nozzle, and that weakens it and leaves the dose in the skin. And here, this video clip from an old smallpox movie illustrates, if it will work, it'll start by two of the methods. This is the bifurcated needle.
Vaccinating millions of people. Even that wouldn't have been enough, not even with the latest vaccine and equipment. But along the way, they discovered something else about smallpox, something that made it vulnerable.
Smallpox moves slowly from person to person.
You can see the technique is rather simple.
So that if you can keep track of where smallpox is, you have a chance to alter the natural course of the disease.
Credit William Fagey with that. As a young doctor working in the villages, he'd found that if you surround smallpox with a wall of vaccinations, isolate it, you can stop it. The strategy of search and containment.
So this is the Pedijet that Bill Fagey is using in Tonga, I believe this is, for a smallpox campaign. Now there are some other alternative cutaneous methods that are not widely used, primarily for BCG vaccine. There's scarification. In fact, a paper just came out, actually was presented at a conference in Boston last month, in which they used scarification to deliver a new tularemia vaccine. I wasn't quite sure exactly how they did. I'll have to get in touch with them. There's the multiple puncture method, in which they take straight needles instead of holding them sideways, as you saw earlier, in which they poke them through the vaccine, liquid vaccine on the skin. There are these multi-tine devices. This is the Kuchiki needle, as it's called, a method it used in Japan and sold elsewhere in the world, that uses the Japanese TB vaccine for what they call, quote, the percutaneous PC method, and that's also my nomenclature list there. And it's still used in Japan and a few other markets. And many of you are familiar with the mono test or the monovac time test that used to be used for skin testing. They're not recommended for that, but they have been used for vaccine in the past. Now let's turn to some of the early clinical evidence supporting cutaneous vaccination. I try to keep up with the literature. This slide's a little bit out of date, but these are the number of papers I've been able to find. I haven't bothered with smallpox and TB because that's the primary, and yellow fever, that's the primary route for these vaccines here. At least it was in West Africa for the yellow fever. But there are over 117, and probably I'm missing quite a few, rabies papers on intradermal rabies vaccination, close to 100 or perhaps more by now on hepatitis B, almost 2 or 3 dozen on influenza, polio, cholera, measles, typhoid, and then a bunch of combination vaccines here. And I've just pointed out there's only one polysaccharide vaccine. Since I'm in bacterial diseases, I need to talk about this. Meningococcal A had one paper by Gottschalk in 72 supporting the cutaneous route, and I'll talk a little bit later about that. But it's a pretty large literature. I can't, there won't be enough time to cover it all, so this is just a brief summary, and then I'll give a few more details on some of these. Rabies has excellent results, and it's already a widely used method in the developing world, and we have some of the rabies people here who know that disease better than I, who can talk about that. So it's widely used for its dose sparing. It's a very expensive vaccine, but life-saving among people who've been bitten a lot of the work was done in Thailand and India and Burma and all those places they're using this. We have good results worth pursuing. I've sort of categorized these from good to bad. Influenza, over 24 papers already, and polio, IPV polio by the intradermal route. I classify mixed to poor results with hepatitis B. Some papers show it works, others show it doesn't, and it seems to work better with plasma-derived than with recombinant vaccine. There are a few papers on measles, and once again, some work and some don't. And as I mentioned, no data except for that one case on any of the polysaccharide vaccines except for that one meningococcal A polysaccharide. So here's a summary of influenza. Let's start with influenza as one of the key diseases of interest. And these are the early papers. The earliest I can find was 1937. And some of these papers are by some luminaries in the pantheon of vaccine history. Tom Francis at the University of Michigan, who led the largest clinical trial of a vaccine, actually the largest clinical trial of any medical intervention in history, which was the Salk polio vaccine trial using a bunch of EIS officers assigned to him up in Michigan and then around the country. Tom Weller, the recipient of the Nobel Prize for figuring out how to grow polio virus in tissue culture. He won that with John Enders and Fred Robbins. And Maurice Hilleman, who died in 2005, probably developed more vaccines than any other person living or otherwise in the world. And these, I don't try to give you all the details here for lack of time, but I use a color coding. If you see green type or green ovals or circles, that means good. It means the intradermal results rather, in terms of immune response, rather better than or equivalent to the subcutaneous on all of these papers going from 37 to 79. And here's a paper also from 1979. I'll go into a little more detail because they interestingly studied both the bivalent vaccine, both the swine flu strain of 1976, you're all familiar with, the A New Jersey 76, and combined with the seasonal strain at that time, A Victoria. They studied 18 to 24-year-old adults who received one dose before the campaign got canceled when swine flu had some problems. And they compared different antigen quantities between intradermal and subcutaneous. And here's the results. You can see that for the swine flu strains here, comparing 0.1 ml intradermally with half an ml subcutaneously, not very good results for either of them. In a sense, equivalent, but both poor in terms of the proportion reaching HAI titer of 40, roughly equivalent HAIs here. But when you look at the seasonal strain, the intradermal dose, 1/5 of the intradermal dose gave 55% with a fourfold rise compared to 39% here, a little better here, and perhaps not as, roughly no significant difference on GMTs. Another example, also comparing the swine influenza to the seasonal strain, was from Herbert, who studied patients 17 to 82 years of age with one dose. And you can see here the swine flu did poorly, and I sort of wonder if this is sort of analogous to what we're seeing, that it's harder to get a good response from avian influenza than it is from the seasonal influenza strains, and they've got to figure out how to get adjuvant or get more antigen into the doses. So you can see it did rather poorly. Both of them did rather poorly, but certainly ID didn't do as well as subcutaneous here, but for the seasonal strain, it was more equivalent. Now, not all of the influenza papers on the ID route are supportive, and there's a minority of reports, probably I would say 20% of them, that in which the ID route performed less well than subcutaneously, or it was uncertain. Boger found in 1957 that when he compared 500 chick cell agglutination units subcutaneously, he got 79% seroconversion, but when he gave 1/10 of that dose, we usually only cut it down to 1/5 in modern intradermal vaccination. He was only getting 36%. Sazlaw found among the non-naive elderly getting a fourfold rise, 1 ml by the subcutaneous route, 60 to 78% seroconversions, but by the ID route only 39 to 56. Siegel studied various ages and various doses, and as far as a fourfold increase, subcutaneous route 78, 88, 77, which was better than the ID route 45, 74, 62, and similarly with Hutchinson, uncontrolled study, but it did not work very well. 11 out of 17 for the swine flu compared to 22 out of 26 seroconverting for the seasonal strain. Now let's turn from influenza to a few interesting slides on polio, and it's interesting to go back to Dr. Salk himself. He actually started out using the intradermal route for his vaccine. And reading his papers, it's actually surprising how confusing and poorly written they are. He takes data from this experiment, mixes it with that experiment, you can't really figure out what he's talking about. But this is his graph. He studied initially an aqueous formulation, went to the famous Watson School and gave the vaccine to 27 children and adults. They received 2 doses, 0.1 ml intradermally, 6 weeks apart, and his results were that the type 2 strain, the Middle East versus 1, had 100% fourfold rise, but he got very poor results with the types 1 and 3 strains, 0%. He hypothesized he had inactivated them too much and he needed to go back to the lab. And he later studied the intramuscular route using larger 1.0 ml doses in a mineral oil emulsion for an adjuvant effect. So basically, he wanted to get an adjuvant effect, and that sort of ruled out the intradermal route. And you can see here the pre-vaccination titers are here, and here are his results, pretty good for at least the MEF1 strain. Here's another of his graphs, tables actually. It's hard to interpret, so I sort of summarized it here. 20 children, 5 adults at the Watson School and in the community, 3 doses, 0.1 ml intradermally 1 week apart. And when he gets a plus symbol here, it means at a titer of 1 to 4. All of the responses with pre-existing antibodies were greater than 4-fold. In other words, type 1 had 100% response, type 2 84%, and type 3 96. Not bad, but as I mentioned, he abandoned that route. Now, when polio vaccine first came out in 1955, the Danes actually delivered it intradermally as the standard route for their population, as reported by von Magnus in 57 and 67, reporting a good immune response in naives, and there were about 2.3 million persons vaccinated in the first 2 years after the program began. 91% of the population from 9 months to 4 years of age got 2 doses. In Iceland, which is connected to Denmark politically, they compared the American vaccine subcutaneously versus the Danish vaccine intradermally, and they found sort of a poor response in general for either route for type 1 and a somewhat lower response intradermally than subcutaneously for type 2. And here's the graph. This is a graph that you can actually replicate easily in PowerPoint. It's a nice visual way to demonstrate. This is the they call it intracutaneous versus subcutaneous. And you can see that there's some decrement here between in the performance of the ID route.